Needle stick injury, post-exposure prophylaxis and management. The topics covered in the previous session include the risk of transmission of blood-borne viruses following a needle stick injury, the activities that put a healthcare worker at risk, the definitions of exposure and needle stick injury, the documentation that needs to be completed in case of an exposure, and the measures to be taken to minimize the risk and prevent such an exposure. This session will cover the stepwise management of needle stick injury, exposure and source codes, post-exposure prophylaxis, and laboratory investigations and follow-up for the exposed healthcare worker. The first step to be taken in case of a needle stick injury is to manage the exposure site. Do not panic and instinctively suck the wound. If the skin is pierced by a needle stick or a sharp instrument or object, immediately wash the puncture site and surrounding skin with water and ordinary soap thoroughly. Do not scrub or squeeze the wound. Do not use antiseptics or skin washes. Do not use bleach, chlorine, alcohol or betadine. And as mentioned earlier, do not put the pricked or cut finger in the mouth in a reflex action. The first dose of post-exposure prophylaxis or PEP should be initiated within 2 hours of exposure. For the benefit of laboratory staff working outside the routine hospital hours, like the evening shift or on emergency night duty, the first dose must preferably be available in the laboratory itself, so that the PEP can be initiated within 2 hours instead of delaying it until the next morning. Following the first aid, as step 2, report the exposure to the immediate supervisor. Next, consult the physician of the institution who has been designated to address incidents of exposure to the healthcare workers, who will then review the incident and assess the eligibility of the exposed healthcare worker for PEP. The need for PEP against HIV will depend on the exposure itself and the HIV status of the source, if the source has been confirmed as positive. It is decided based on exposure and source code. While the need for PEP against hepatitis B will depend on the vaccination status and the anti-HBs antibody titer levels of the exposed healthcare worker. So first, let us understand exposure code. Exposure is categorized as mild, moderate, and severe and coded as EC1, 2, and 3 respectively. Mild exposure or EC1 refers to an exposure to the mucous membrane or non-intact skin with a small volume or for short duration. Example, a superficial wound or an erosion of the epidermis caused by a low caliber or a small bore needle, or a splash onto the conjunctival or nasal mucous membranes. Next, a moderate exposure or EC2 refers to an exposure again to the mucous membrane or non-intact skin but with large volumes or for long duration, or it could be a percutaneous superficial exposure with a solid needle. And finally, severe exposure or EC3, which refers to percutaneous exposure with large volume or a large bore needle, probably more than 18 gauge, which is visibly contaminated with blood, or a deep puncture with a needle stick or a sharp object that has been previously used intravenously or intra-arterially, thereby leading to contact with a significant volume of blood. Next, let us look at source code. A source is the patient on whom the needle was used prior to the accidental prick to the healthcare worker. Now, the source patient could be HIV negative, in which case he or she should be tested for other blood-borne viruses such as HBV and HCV. If the source is HIV positive but clinically asymptomatic with high CD4 T cell count and a low viral load, he is categorized as low risk or SC1. If the source is HIV positive but clinically symptomatic with low CD4 cell count and a high viral load, then he is categorized as high risk or source code 2 or SC2. In instances where an unattended needle or improperly disposed needle has caused the prick, probably during management of biomedical waste by the housekeeping staff, it might be impossible to trace and identify the source patient. In such cases, the status of the patient will remain unknown and neither the patient nor his or her blood will be available for testing. The National AIDS Control Organization provides guidelines on giving PEP for HIV based on the exposure and source codes. PEP is not warranted for persons who have had a mild exposure from a source who is HIV positive, clinically asymptomatic with high CD4 counts and a low viral load. However, it is recommended for persons who've had a mild exposure but from a source who is HIV positive with clinical symptoms, a low CD4 count and high viral load. It is also recommended for persons with moderate and severe exposures, that is with exposure codes 2 and 3, and when the source is HIV infected irrespective of the viral load levels, that is both for source codes 1 and 2. If the source is unknown, consider giving PEP if the HIV prevalence is high in the given population and based on risk categorization. PEP for HIV is given for 28 days. It is important to complete the full course of PEP. As mentioned earlier, the eligibility for PEP for hepatitis B depends on the vaccination status and antibody levels of the exposed healthcare worker. If the exposed person was unvaccinated, administer hepatitis B immunoglobulin within 48 hours of exposure and initiate the full hepatitis B vaccination, which consists of 3 doses given at 0, 1 and 6 months. If the exposed person was vaccinated and their antibody titer level was greater than 10 milli-international units per ml, no specific PEP needs to be given. The individual only needs to be reassured. If the exposed person was vaccinated but their antibody titer is less than 10 milli-international units per ml, administer the hepatitis B immunoglobulin and 1 dose of the hepatitis B vaccine and plan to revaccinate as seen necessary. If the exposed person was vaccinated but does not know their antibody titer levels, test for anti-HBs titer levels and then take appropriate action. If the exposed person is found to be hepatitis B surface antigen positive, it means that they were infected previously and is now a HBV carrier. In such cases, there is no specific PEP available. The individual needs to be counseled. The third step in management is counseling. This is particularly important when PEP for HIV is given. The exposed person should receive appropriate information about PEP, its risk and benefits. They should understand details of the window period, baseline tests, drugs that are used, their safety, efficacy, and side effects. They should be counseled on safe sexual practices till both the HIV tests conducted at the baseline and 3 months after the exposure are found to be negative. They should be given psychological support and special leave from work if required. Step 4 is prescribing PEP. For HIV, it is most effective if initiated within 2 hours of exposure. This is the golden time period. There is only minimal benefit if more than 72 hours have lapsed since the exposure. However, if a healthcare worker reports the incident and presence greater than 72 hours after the exposure, he or she must still be initiated on PEP. PEP is given for 4 weeks or 28 days. Later, if the risk is found to be insignificant, that is, the source was traced and was found to be HIV negative or source code 1, then PEP could be discontinued if it was already started. PEP for hepatitis B includes hepatitis B immunoglobulin and HPV vaccine. I hope you've noticed that so far I have addressed PEP for HIV and HBV only. This is because there is no specific PEP or vaccine available for HCV. Step 5 is laboratory evaluation. It is recommended to assess the baseline serostatus of the exposed healthcare worker by testing for HIV, HPV, and HCV within 6 days of an accidental exposure. If the exposed healthcare worker is found to be HIV positive, then discontinue the PEP regimen as the person needs to be referred to an ART center to be initiated on appropriate ART regimen. Please remember that prior to the testing for HIV, an informed consent must be obtained from the exposed healthcare worker. He or she cannot be tested forcibly or against their will. The parameters tested for in the baseline investigations are HIV antibodies, HCV antibodies, anti-HBs antibodies, complete blood count, and liver function test including liver enzymes. Step 6 is the follow-up of the exposed person. At 2 and 4 weeks after the exposure, the complete blood count needs to be tested. At 6 weeks after the exposure, HIV antibodies is repeated and HCV RNA is tested if possible. At 12 weeks or 3 months after the exposure, HIV and HCV antibodies and liver function tests are repeated. At 24 months or 6 months after the exposure, similarly, HIV and HCV antibodies and liver function tests are repeated. So, to summarize, we have understood the varying risk associated with the different blood-borne viruses and the different activities that put the healthcare worker at risk, the preventive measures that are to be taken to minimize the risk and improve safety at the workplace, overall management of any exposure and needle stick injury in particular, including the first aid to be given, the categories and codes, the PEP, its duration, and the relevant supporting investigations. Learning and understanding all about PEP for needle stick injury and its management will all be in vain if the exposure when it occurs is not reported. Hence, always ensure that an exposure or a needle stick injury is reported. Thank you.